Thank you, Nuno. Let's move on. The next segment of this meeting will be moderated by Jaime Branco, which is, I already introduced him, but let me do it again. He is a full professor at Nova Medical School. He is a clinical assistant at the Egas Muniz Hospital. He's a rheumatologist by training, and he's also a member of the organizing committee of this meeting. So without further ado, Jaime, the floor is yours. He will take us all the way to lunchtime, so I can relax. I don't have to worry about time. That's going to be your job. Thank you, guys.
Well, good morning, everybody. First of all, I want to thank for the organization of these conferences, and Joan is really the really motive for us to be here and for doing this effort and this second conference. And I want to thank Joan Hoffman for that. And I think all of us, patients, medical doctors, other professionals, must be grateful for this initiative and this, how to say it, energy she has. She thinks that she has no energy, but she has full of energy when she thoughts to help other people to manage it. And it's about it what I'm going to talk in this first block. Diagnosis made, patients asks for answers, several answers. And therapeutics is one of those answers, and one of the most important of those answers. And as you know, all these clinical entities, ME, CFS, and long COVID, can be classified as post-infectious syndromes, and we don't know already, and really physiopathology of these entities. So it's very difficult to treat this type of diseases of syndromes. But there are answers we must give to our patients. They must continue to live, to work, and to be in family with friends, and they must have answers to give to their husbands, their children, and mostly of the difficulties I see in my patients is they have no answers from some of our colleagues, and that is in addition with their disease, another disease, and we must apologize those patients who have months or years or without treatment, or even without diagnosis. And this first block maybe can accelerate some of our knowledge, and so we hope to have some highlights evolving approaches to the treatment of these clinical entities. We are going to have 4 talks, and the 2 first are online. Colleagues are not here with us, Susan Levine and Danilo Bonosenso. And after the coffee break, we have two presential talks from Caroline Kingdom and Luis Nakul. After each talk, we can have one or two questions, but we have a period before lunch to have questions and answers from our colleagues, and also to discuss the four presentations. Okay, are we ready to have the first presentation of Susan Levine? Well,
Hello, it's great to be here and to be part of this effort by my friends and colleagues in Portugal and elsewhere to enrich the knowledge base on ME/CFS, chronic fatigue syndrome, myalgic encephalomyelitis, and on long COVID. Briefly, there are parallels between these two conditions, and the only silver lining relating to the advent of long COVID is that scientists are able to study the pathophysiology of these similar conditions closer to the onset of illness or disease process. My focus today will be on discussing 4 novel treatments that are being used to treat these conditions. In addition, if there's time, I will introduce some yoga poses or asanas that I have found helpful in reducing excess sympathetic output in patients with ME. The first of these medications that I'll discuss is rapamycin, which many of you have heard of, I'm sure, and there's been a recent publication as well. Rapamycin relies on the absence or depletion of an autophagy protein, ATG13, which in mouse models who lack this gene develop severe fatigue after running on a treadmill. Rapamycin acts to enhance the production of this autophagy protein and thus may help with fatigue. The second group of molecules that I'm going to discuss are plasmalogens. These are lipids containing a novel chemical structure and which are also found to be depleted in both ME/CFS patients and in those with COVID, long COVID. They appear to be depleted in ME/CFS and in normal aging, in Parkinson's disease, and also in Alzheimer's. The group that I'm part of, Centers for Solutions at Columbia, has published in the past on diminished numbers of peroxisomes, which are little organelles in the cells that normally produce plasmalogens. So this is an interesting area of research, and I think these supplements, the plasmalogens, are very well tolerated and could be very helpful. The next set of meds I'll discuss are the GLP-1 inhibitors, which have anti-inflammatory effect. These are the drugs that were originally developed to treat diabetes, elevated cholesterol, and help in weight loss. These medications, which act by enhancing glucagon, which is a hormone that regulates blood sugar, also, interestingly enough, have a strong anti-inflammatory and specifically mast cell stabilizing properties and optimize glucose and insulin metabolism. My practice is using this quite a bit, and thus far we've had some success. It's early days, but the good news is they don't seem to cause the gastrointestinal side effects that are found in the higher doses of these medications. I'll also discuss briefly oxaloacetate, which many of you have also heard about probably, and on which there's been a few publications. Oxaloacetate is part of the Krebs cycle, which helps us derive energy from food, and which is not working as well in ME patients. The aerobic metabolism in ME is faulty, and so many patients utilize the less efficient anaerobic pathways for energy. So let's go back to start our discussion with rapamycin. As many of you know, there have been very few interventional studies done in ME patients. Part of the reason is, of course, lack of funding for this orphan disease, which is so prevalent and causes so much devastation around the world, but also the lack of a reliable biomarker that can be followed to determine whether a person is responding to a particular intervention. And the lack also, surprisingly, and this is a little difficult to explain, but of normal control or a placebo that could be available to offset the study drug. So that actually was an impediment in the rapamycin trial. So this study was done in part by the Bateman Horne Center and Doctors Kaufman and other doctors on the West Coast in the US. And they used this novel drug, rapamycin, which was originally developed to prevent organ transplant rejection. So it has mild immunosuppressive properties. However, when people hear that, they think that they're going to really suppress their immune system, but it's actually relatively mild. And in people who have a normal immune system, it hasn't caused any further deterioration. Rapamycin was studied, as I said before, in about 80 ME/CFS patients as part of this recently published study. And they used several different doses, but the doses they found most successful were 6 milligrams weekly. And they worked up to that. And we do that too in our practice. We start out with 1 milligram weekly for a month and then escalate by 1 milligram every month. So the second month is 2 milligrams weekly, et cetera, until we reach the 6 milligram weekly. And what they did was this group studied bloods every month and found that there was an increase in the autophagy producing capability of the patient, statistically significant over those patients who did not receive the medication. So what it's doing is it's augmenting the capability of the immune system to rid itself of abnormal, like cellular detritus, the things we don't need, and therefore improve the inflammatory situation. And this in turn led to improvement in patient subjective complaints by measurement with fatigue scales, standardized fatigue scales, like the Beck Depression Inventory, the Chardin Fatigue Scale, and others, found a fairly robust improvement in fatigue by the use of rapamycin. What was missing from this study was an adequate placebo. There were problems with developing a placebo drug that would adequately mimic and taste the same as the rapamycin. So in other words, the people who reviewed the study couldn't arrive at a good placebo. And that's often a problem because people can discern whether so it's not a completely double-blinded study. But in any case, it's well constructed, and they're doing more to enhance it. There's a second study that's currently ongoing, and that is going to include more principal investigators. So I think the thing to do here is to monitor the patient monthly with CBC and chemistry profiles, and to, try to reassure the person that these are not heavily immunosuppressive drugs in most cases. Let me move on to the next category I wish to discuss, which are the plasmalogens. These are available through various internet-based stores. There's a long COVID store, and I can provide the access to that later. And once again, these are lipids or fatty molecules that have a novel chemical structure and that are found to be low in patients with ME. And again, there have been several publications which showed altered metabolism of fats in people with ME, too few middle chain size fatty acids, and that leads to inadequate reduction of neuroinflammation, specifically in the brain. And mast cells largely reside in the brain. People think of mast cells as allergic cells only that can cause congestion and the typical allergy, hay fever symptoms. But mast cells are actually responsible for producing pain, sleep issues, and memory loss in ME/CFS. And anything we can do to reduce the production of these inflammatory cytokines, specifically in the brain, is beneficial. So these plasmalogens are a group of molecules, and I'll provide some more specific information about potential dosing of these, and which are typically front-loaded in the beginning of treatment. So one would start with 3 times the final dose to take that for 2 weeks, and then end up taking 2 tablets daily thereafter. So we start out with 6 tablets daily for 2 weeks, and then continue with 2 tablets afterwards. Again, I think it's helpful for patients, and we're trying to develop what the best, least inconvenient method is for patients to assess how they're reacting to these medications. So sometimes people keep a diary. They have apps where they measure like the number of steps they can do, and we're trying to develop on an app-based assessment tool where people can weigh in on reduction of sore throats, pain, improvement in sleep, quality of sleep, ways of measuring the benefits or side effects of these different interventions. Now, let me come to the GLP-1 meds group of drugs, which rely on the enhancement of glucagon producing capabilities. So glucagon is the opposite. It's a hormone that's kind of the opposite of insulin. And what it does is it enhances the body's response to changes in blood sugar. And there's evidence that there's some impairment of that in ME patients, and also in patients, obviously, with diabetes and hyperlipidemia, and in obese patients. The drawbacks of the GLP-1 drugs have been in the media and have largely been related to GI side effects and pancreatitis. We have found that at about 1/20th of that dose, that there actually is some improvement in ME patients in terms of lessening inflammation, improving fatigue, and there's some evidence that these group of meds also reduce mast cell products. And so obviously that ties together very nicely with our theory that a large part of the physiology behind ongoing symptoms in ME patients is this persistent inflammation. So, I think this is an interesting area to pursue. The last supplement that I'll discuss is oxaloacetate, which has been written about a little bit, and I'm sure people have seen it on the internet. Oxaloacetate is a component of the Krebs cycle, which is the human respiratory cycle, which typically uses oxygen to promote metabolism of sugars and carbohydrates like glycogen. Oxaloacetate seems to be missing or depleted in a lot of people with ME. And so as shown also on some of the 2-day CPETs, and if anyone in the audience has ever seen someone like Betsy Keller or seen David Systrom, they know that preferentially in ME patients use anaerobic metabolism, which is much less efficient than aerobic metabolism. So the theory behind providing oxaloacetate to patients is that we can switch over the mechanism of oxygen and energy delivery to tissues with the use of this supplement, oxaloacetate. Again, the dosage hasn't been completely worked out. People usually recommend a loading dose of 2 500 milligram tablets twice a day for 2 weeks, and then down to 500 milligrams or 1 gram daily, depending. The dosing on a lot of these things is iffy because, again, there haven't been large studies to determine optimal dosing. And I suspect it varies from patient to patient anyway. So that's oxaloacetate. And there are other molecules like this, like carnitine is another example of a supplement that's part of the Krebs cycle that has also been found to be depleted in ME patients.